Hello, everyone. Thank you so much for your patience. We're working on some technical issues behind the scenes, but we have three wonderful presenters. We're just trying to patch our fourth presenter and our additional, our moderator into this session. So that's all happening behind the scenes right now. But thank you all so much for joining and for your patience. So we are really excited to have a session for you entitled, let me pull up the title right now, ACS, how using the ACS data for planning. And we have a presentation from Tiffany Kindrat, from Pei-Yang Shi, from Erica Moore, and Chase Sawyer. So right now, without further ado, I'm going to turn it over to Tiffany. And Tiffany, if you would like to give a little introduction about who you are and where you're from, I think that would be really helpful for the audience. And the rest of us will hide ourselves as you present. Thank you. Oh, Tiffany, you can unmute.
Yeah. Let me go ahead and pull up the presentation right here. Let's see. Okay, come on. Entire screen. Okay. All right. So I should be sharing my screen now. And can everyone see the presentation?
Yes, thank you.
Okay, perfect. All right. So my name is Tiffany Kindrat. I'm an assistant professor at the University of Texas at Arlington. A lot of my work focuses on the use of large databases. So it goes anywhere from looking at racial and ethnic health disparities and how those contribute to health across the life course, to patient-provider communication and how that contributes to health. And so I've done a lot of work with helping trying to segregate the Middle Eastern and North African identifier that we learned more about will be implemented in the ACS this morning. But then I also do some other work with people focused on maternal health and racial and ethnic health disparities in that area. So today, that's what I want to talk about, is really talking about how we're using the ACS data as part of a much bigger systems dynamic group modeling project on maternal health, and particularly severe maternal morbidity in Texas. So just a little introduction in the topic area. So severe maternal morbidity is defined as any unexpected health conditions that occur during or shortly after childbirth. So non-Hispanic Black women have a large disparity compared to non-Hispanic white women, and it increases their risk for maternal mortality. Texas has extremely high racial and ethnic health disparities in maternal health, particularly related to maternal morbidity and mortality. So my team is Project Impact. And so this is a collection of two different grants that we received, one from HRSA and one from National Institute of Minority Health and Health Disparities, to create these different models to try and address this within Texas as a whole and within North Texas. So Project Impact, the impact stands for Improving Maternal and Reproductive Health using Complex Simulation Techniques. And we're using ACS data as part of this larger model. So the overall goals of Project Impact, there are two specific aims. So the first is to generate a holistic, complex systems grounded understanding of the different multi-level webs of factors that contribute to the systems and systems of systems that generate severe maternal morbidity disparities among non-Hispanic Black women in Texas. And this is being done using primary and secondary data sources. Then once this model has been created, the idea is to translate that information into an evidence-based guidance simulation model and different web-based tools that can be used for interventions within the community. So just a little background on what has been done so far related to primary data collection. So before even getting to the point where we want to use ACS data or any of these other data sources, there were these community group model building sessions. And so there was a session with 19 different community partners. They came together to sort of discuss all of the different complex systems that can contribute to severe maternal morbidity outcomes among non-Hispanic Black women in Texas. So these are, things like job opportunities, things like policies, a wide range of all of these systems level factors. And so to translate that into a qualitative simulation model, our model builder, who is an engineer, uses multiple different secondary data sources to try and quantify how these feedback loops come together and how these different factors influence whether someone maintains a pregnancy, whether they have pregnancy with maternal morbidity, without, and ultimately reducing maternal mortality. So in this presentation, I'm just going to describe the data from the ACS that we're using as part of this simulation model building process. And so ACS is one of multiple different secondary data sources that we're using. So not only are we using ACS, we're using the behavioral risk factor surveillance system, mainly because you can actually get a state level identifier there. So ACS allows the state level identifier, and so does the BRFSS. We're also applying for some national vital statistics system data that can give us that state level indicator as well. And then we've been looking into some Texas inpatient databases to try and figure out some of those ICD-9 codes for the very severe maternal morbidity and the different health outcomes that happen after birth that can't be captured by these national data sets so far, and some other state health statistics. We've been looking into using things like PRAMs, but every time we go and get PRAMs, there seems to be some issues right now with the data accessibility there. So we're just trying to find what sources we can use. But I mentioned before that I've used ACS for a lot of other studies. So the first thing I knew when we needed to look at how many women of childbearing age there were in Texas, how many women gave birth in the past 12 months, and how many people were entering that childbearing age mechanism, stock and flow, I knew the ACS data would give that to us. Then we're also using the behavioral risk factor surveillance system data to look at the comorbidities by race and ethnicity. So there's not a lot of that health information in ACS that's publicly available. So we're able to use the BRFSS for that. Then I'm currently looking at pregnancy duration among non-Hispanic Black women with any maternal morbidity or with mild, moderate, severe maternal morbidity, as well as mortality rates using the National Vital Statistics data. And then we're using these other data sources to look at different things like pregnancy duration among women that have these severe maternal morbidity outcomes, as well as things like pregnancy termination and mortality rates that have occurred during labor and delivery and postpartum. So in the next few slides, I'll just discuss the different findings for what we're using, and they're very basic, but I put together some different graphs with some trends so you can see how our model builder uses the ACS data. So we wanted to have around a 20-year time frame, and since the ACS data starts in 2005, we have from 2005 to 2024, and we have a number for women of childbearing age and a number for women who gave birth in the last 12 months. We have limited our sample to ages 18 to 49 for childbearing age, mainly because we want to do those comparisons with the other data sources like the BRFSS, and we cannot get that 15 mark like some of the maternal and child health indicators would say to start at age 15. And so we want consistency across that. Then we also need to know the number of women who transition into this childbearing age group each year. So we calculate the number of women ages 18 in Texas each year. And so just going over here, you can see we calculated just the unweighted ends per year, the frequency, and then the weighted frequency. There's a total at the bottom. They're not meant to be looked at as this collective number, but it just shows the different trends that has been increasing since 2005. So there's been an increasing number of women age 18 to 49 years old in Texas from 2005 to 2023. Then we also needed to know the women ages 18 to 49 who gave birth in the last 12 months. And here you can see there's a much, bigger like dip in the numbers, but also my scale here is much smaller compared to the last one. But you can see here that the some of the lowest rates, so there was the weighted numbers 315,788 women in 2012 compared to in 2021, there was 426,440. So these are women who gave birth in the last 12 months. So definitely some different variation of highs and lows there. But when you put them together on the same scale, you don't quite see as much variation. You can still kind of see some of these little dips here, but for the most part, it stayed pretty consistent compared to the increase in the number of women. And then we looked at the women age 17 only, so those transitioning into the maternal and child health, the reproductive age here. And we can see the lowest weighted number was in 2005 at 161,773, with the highest number in 2022, which is this one here, the 223,580 weighted there. But again, you can see more variation, but the scale is much smaller compared to that total population size. So some other data, the variables that we're considering looking at here as we put all the different factors together, other demographics, things like whether people are married when they give birth or they have couple families, citizenship, as well as economic factors such as occupation, earnings, insurance, and housing. A lot of that was identified in the preliminary primary data collection. And healthcare, the ACS, we probably will not use for healthcare related variables because the only ones accessible that were directly healthcare related were disability as far as a health outcome, not healthcare access or anything like that. So just as a summary, our base model includes 869,890 women of childbearing age in Texas, which represents over 113 million across this different time period. Among them, there were 62,012 women who reported giving birth in the last year, and it ranged from about almost 2,000 to 3,735 across the different time points. Then we did have a total number of 32,383 women aged 17 in Texas, ranging from around 1,000 to almost 2,000 entering that reproductive age period per year. And just some of our next steps really is to look at these additional data sources and try and find the estimates needed for severe maternal morbidity. So I can look to see if someone has gestational diabetes, hypertension during pregnancy, diabetes or hypertension before pregnancy, things like smoking, but I can't really get into the data on what causes certain birth outcomes with these national data sources that I mentioned. So trying to find some of the state level data would be very helpful. And then once we complete this model, we'll be able to translate this into an evidence-based simulation model that can be used for designing interventions, particularly targeted at non-Hispanic Black women in Texas, with the potential for replication in other states. Okay, and so this is a collaboration of my lab, which is the Health Survey Research Lab, and led by the Maternal and Reproductive Health Equity Lab at UTA. And then we're also working with people at University of Houston, UT Health Science Center in San Antonio, as well as Cal Poly Tech University. And that's it.
Great. Thank you so much, Tiffany. And now we have next Pei Yang She, who will be presenting.
Hi, thank you so much. I'm going to share my screen. All right. Hi, everyone. I'm Pei Yang Shea. I'm an epidemiologist with the Santa Clara County Public Health Department. And today I'll be presenting on mapping ACS demographic data to assess extreme heat vulnerability in Santa Clara County. So briefly, a bit of background. Santa Clara County is located in the San Francisco Bay Area in California. A large part of our county is also known as Silicon Valley. You can see on the map image on the right here, the red borders of our county. And in our county, community demographics and health status factors really play a role in determining vulnerability to climate impacts and extreme heat. Based on our Essence data from May 2024 to May 2025, we saw that the areas around the cities of San Jose and Gilroy had the greatest number of heat-related illness and deaths. So we wanted to dig into this further, and we realized that local data is needed to better understand the adaptive capacity of different populations in our county, and we wanted to see which populations were more vulnerable to extreme heat. So we got funding from the CDC BRACE grant to do this work. And so we selected indicators based on conducting literature reviews and looking at things like the CDC Social Vulnerability Index to find populations that increase risk for adverse health outcomes due to extreme heat. You can see here a list of the data sources that are listed. We primarily pulled from the ACS data, but other data sources we pulled from were like state data or local data as well. We gathered all this data and we aggregated it by zip code and census tract for each indicator, and then we mapped and presented it on a publicly available ArcGIS story map. And here is just the list of the indicators on our story map that use ACS data. You can see it ranges from age and race ethnicity, population living in poverty, living alone, outdoor workers, as well as like housing units and disability. And so now I'll go into a demo of our story map. Feel free to scan the QR code for access to it, or there's a link there too. I can share the link in the chat after as well. But let's dive into the story map itself. So here is what our story map looks like. At the top here, you can see there's 3 pages. There's demographic and socioeconomic factors, there's health status factors, and there's West Nile virus. And so starting with the demographic and socioeconomic factors, as you scroll down here, you'll see these are each of the indicators we have on this page. You can click on any of them and it'll jump like straight to that indicator. But I'm going to go through them so we can see it together. So starting with population ages 65 years and older, we have a little blurb on the left here about the indicator and why we selected it. In this case, older adults are more vulnerable to heat, which puts them at increased risk for heat illness and mortality during extreme heat events. And then on the right here, you'll see our map. You can click on this button to expand it like so. And then on the left here is the map by zip code, and on the right is the map by census tract. And you can drag this divider in the middle to see and to compare the 2 split screen maps. At the bottom left here, you can click to see the legend. So this is showing, darker colors indicating higher percent of the population being 65 and older. For both maps, it's the same legend. And just focusing on the zip code one for now, you're able to click on any of these zip codes, like so. You'll get a pop-up here. You can click the zoom to button like this, and it'll zoom into the map to the zip code that you selected. The pop-up tells you the total population for that zip code, as well as the number of people who are ages 65 and older, as well as the percent who are ages 65 and older out of that total population for the zip code. And just to note that data are masked for geographies with total population count of less than 1,000. So you'll see that in like grayed out, basically. And you can always exit out of this and click the home button on the right here if you want to zoom back out to the default like full county view. And it's the same thing for the census tract. So again, looking at this map, you can see the darker areas have higher proportion of the elderly population in our county. And then you can just click here again to exit out the expanded view if you wanted to look at other indicators. So we also have population under 5 years old because young children are also at increased risk. They're less able to regulate their body temperature, and they may be too young to be able to clearly communicate their needs to caregivers. So again, you can just see on the map here by zip code and census tract where the children may reside in our county. And then we have race and ethnicity data. I won't go through each of these in detail, but we have African American population, we have Asian population, here's Latino population, we have white population, and then we have an aggregate summary group of population of color, which is just defined by all non-white residents. And then moving on, for poverty, we have population living 200% below federal poverty level. We chose the 200% cutoff because our county is in a pretty high cost living area. So we usually use 200% as an appropriate way to try to capture folks who may be living in poverty. So again, you can see here just the same split screen maps. And then we have population living alone, since living alone may make people more vulnerable to social isolation and heat wave effects. They may also be more challenging to reach during emergencies if they're living alone. So the map helps us identify where those folks may be as well. And then we also have population ages 65 and older and who live alone. This is highlighting the importance of, the intersection of different identities and risk factors. And so we definitely want to be cognizant of folks who may have multiple risk factors like this, and they may face additional challenges such as evacuating or traveling to cooling centers. Here we have outdoor workers. So this one is showing workers in agriculture, forestry, fishing, hunting, and mining industry. And then we also have workers in the construction industry. And then we also have workers driving alone. Solo commutes by car could have a negative impact on personal health, air pollution, and greenhouse gas. So this was another one that was identified by us. Again, you can see here that the darker areas are where the higher proportions may be. And then we also have housing units built before 1980, since older homes may not include features such as adequate insulation or air conditioning that helps mitigate the effects of extreme heat. So you can see those housing units are primarily in the northern part of our county, showing in both census tract and zip code. And then here's the probability of no air conditioning. This isn't ACS data, but it's another one of our indicators where we modeled the probability that a household may not have air conditioning in the city of San Jose in the middle here, using various household characteristics. And then at the bottom of the page is where all the sources are. So this is where you can find information for our literature review references and also the data years and ACS data tables that we specifically used for the data that we show on our story map. And then moving on to the second page for our health status factors, see here we have disability, asthma, and births. So it's showing for disability, we have population with ambulatory disability here. And then we also have population with cognitive disability mapped here. For asthma, this isn't ACS data, but we have asthma-related emergency department visits among children ages 0 to 17-year-olds available by zip code only. So you can see that on the map here. And then for births data, which is from our vital statistics data, we have low birth weight since this is another one that was highlighted as a potential risk factor to extreme heat. And then we also have preterm births here. And again, at the bottom is our sources. And finally, our last indicator on the story map is West Nile virus. Again, this is not from ACS data, but we did map out where we're not able to map out where the cases are due to small counts, but we mapped out where mosquito pools may lie in our county. And you can, again, see it by census tract as well as a zip code map. So then going back to the presentation. So in conclusion, our story map was able to help us identify zip codes and census tracts with larger proportions of high-risk county populations. It visually emphasized patterns and risk disparities for climate vulnerability among our county residents. And since this story map is publicly available, we were able to share it with community partners to work in response to extreme heat events and help them guide their decision-making processes, such as where cooling center locations could be most helpful. It helps guide policy and planning, especially in our county, which is very diverse. We have a large immigrant populations, so we want to have thoughtful consideration of varied risk levels, linguistic needs, cultural differences, and also looking at existing disparities and socioeconomic factors connected to climate impacts. And with that, thank you so much. Feel free to reach out and contact us. My personal email is here, as well as our science branch department email. Thank you.
Thank you so much. We really appreciate it. Next up is Erica Moore.
Thank you. Let me go ahead and share my presentation here. Can you see that?
Yes, we can.
Okay.
Thanks.
All right. Thank you. Hello, everyone. I'm Erica Moore. I'm a senior demographic analyst at New York City's Department of City Planning. Sorry. And today I'm going to present New York City's case for greater language detail in the American Community Survey summary file. So New York City is home to 3.75 million people who speak a language other than English at home, and nearly half of them have limited English proficiency. They are essential workers across industries, healthcare, construction, small businesses, etc. But they also face barriers accessing public services. And to serve them effectively, did my presentation disappear? Sorry. To serve them effectively, we need to know what languages they speak and where. And so fortunately, the American Community Survey, or ACS, collects data on the limited English proficient population, but the summary file only includes a limited number of those languages. So today I'll explain why more detailed language data is critical and how improving it could help cities like New York better serve our incredibly diverse communities. Okay, so here's our quick overview. I'm going to begin by explaining how we identify the limited English proficient, or LEP, population in New York City. along with some examples of how we serve their needs. And next, I'll walk through a case study on selecting poll sites for language services, highlighting the difference in outcomes when we have detailed tract level data versus when we don't. And then finally, I'll close with our plea for greater detailed language data. Okay, so let's dive in and start with the foundation to this presentation, the language data in the ACS. So on the left side of the slide is the question from the ACS questionnaire. It asked everyone ages 5 and over, do you speak a language other than English at home? And if yes, what is that language and how well do you speak English? Anyone who answers less than very well is considered to have limited English proficiency or LEP. So on the right side of the slide is how this breaks down for New York City. So 23% of our residents, 5 and over, fall into that LEP category, or that purple section of the top left-hand side of the pie. And in other words, nearly 1 in 4 New Yorkers may need language support. Among New York City's LEP population, 47% speak Spanish, about 20% speak Chinese, and the rest span hundreds of languages from Russian, Bengali, Haitian Creole, Korean, Yiddish, and so on. And these languages aren't evenly distributed across the city, so local context really matters. Okay, so limited English proficiency can create real barriers to accessing essential services. And so we just have a few examples of how we serve the LEP population in New York City. So first, ahead of the decennial census, we produce multilingual brochures to better engage diverse communities and encourage participation. During the launch of the Affordable Care Act, we used language data to identify neighborhoods with high concentrations of LEP residents. And then we partnered with community organizations to provide in-language enrollment assistance and translated materials. All of that resulted, of course, in an increased signups in underserved communities. And under New York City's language access laws, agencies are required to provide interpretation and translate key documents into top citywide languages, also derived from the ACS data, ensuring that LEP residents can access essential benefits and participate in community meetings without language barriers. Our libraries also use this data not just to stock books in multiple languages, but to actively engage LEP parents in their children's education and also in the community. And we use this data for poll site planning, ensuring language assistance is available where it's most needed. And that brings me to our case study. So let's look more closely at this. And under the 1965 Voting Rights Act, the city must assess which poll sites need translation services for specific language groups. This is a multi-stage process led by the Department of City Planning in partnership with the Board of Elections and the Law Department. It blends data from the ACS microdata, ACS summary file, and surname information from the actual voter rolls. And while Spanish is separately mandated, the city also provides language services for Asian communities, specifically for Chinese, Korean, Bengali, and Punjabi speakers. The goal is to ensure that voters with limited English proficiency can understand and participate fully in the voting process, while still allocating the city's limited resources efficiently. Okay, so here's our core data challenge. In 2016, the Census Bureau updated its language coding, which reduced the number of languages reported in the summary file. At the tract level, we now only get 12 individual or broad groupings of languages listed in the middle of this slide here. To access more language detail, we now turn to the public use microdata sample, or PUMS file, which includes 139 individual languages. And a few of these are shown on the right, but the lowest level of geography for the PUMS data is the PUMA, and that covers a minimum of 100,000 people per area. So this limits our ability to pinpoint needs locally and poses a challenge for things like poll site planning. So for example, we get Spanish, Chinese, and Korean LEP data at the track level, but Bengali and Punjabi are grouped under other Indo-European. So let's walk through a methodology using Korean as our case study. First, using the published tract level LEP data, and then modeling what it would look like if we didn't have that detail. So, as I just said, we have that tract level data on the Korean LEP population, but the citizen voting age population with limited English proficiency, or what is referred to as CVLEP, by selected Asian race, is our key target group for language assistant planning. And we do not specifically have that information at the tract level. So the first step in our method is to estimate the Korean CVLEP population using the PUMS data at the PUMA level. And so from the PUMS data, we first identify individuals who meet all the following criteria. If they're limited English proficient, if they identify as Korean, if they're 18 and over, and if they're US citizens. Okay, so next we calculate the share of the Korean LEP individuals who are also CVLEP by PUMA. And in this PUMA that I've highlighted here, which represents Flushing, Queens, 53.7% of Korean LEP speakers are CVLEP. So here I've zoomed into a few tracks within that PUMA. And for Korean, as I've mentioned, we're very lucky to have that track level LEP data directly from the summary file. And those values here are shown in black on the map. But again, we don't have that CVLEP data at the track level. So we apply that 53.7% at the PUMA level to each of the track's Korean LEP population, giving us an estimated Korean CVLEP population by tract. And then we match tracts to poll site areas using the voter distributions, which are available at the tract and poll site area. And for this circled poll site here, we estimate 26 Korean CVLEP individuals. To determine whether a poll site needs language assistance, there's two criteria that need to be met. At least 50 Korean CVLEP individuals from this derived ACS method, and at least 35 Korean voters based on the surname matched voter data. Today, I'm only showing the ACS side of the method because the voter data is confidential, but this site falls below that 50-person threshold, and it wouldn't qualify for language assistance. Okay, so now let's say we didn't have that tract level Korean LEP data like we don't for Bengali. So instead, we model using the Asian and Pacific Island languages that Korean would fall under, grouped as a proxy. Okay, so we repeat the CVLEP calculation, this time using Asian and Pacific Island languages as the denominator. And here, only 7% of the broader LEP group are Korean CVLEP. We apply that 7% to the tract level estimates for the broad Asian and Pacific Island LEP group. And the results come in with some big changes. The census tract at the bottom of the screen, that 849.01, had 0 Korean LEP speakers in the published summary file data. And this modeled methodology now estimates 164 Korean CVLEP individuals. So you can already see how using the aggregate group can significantly change the income. Now back to that same poll site area using the modeled approach, we estimate 428 Korean CVLEP individuals. And that's a huge difference from that 26 CVLEP individuals in our earlier and more accurate estimate. And so now this poll site would actually be flagged for needing Korean assistance. So finally, zooming back out to our 285 poll site areas in Queens, and here's what we see. So the green areas are poll sites that meet the thresholds in both the actual and the modeled methods. The most of the 3 categories here, which is pretty good. The blue areas meet the threshold only when using the actual Korean LEP tract level data. And the red areas meet the threshold only under that modeled approach. And so what does that tell us? Well, when we're forced to rely on aggregated language groups as a proxy for specific languages, the results can be inconsistent and at times misleading. And this highlights a critical point. Of course, the need for more detailed language data at the census tract level. And why does this matter? Well, because decisions based on inaccurate estimates don't just waste valuable resources, they can result in failing to serve the very communities that we intend to support. And so finally, I'll leave you with this. This was just one example, but in our polyglot city like ours, similar data challenges arise across many of the services we provide. As I've shown, we're often limited to PUMA level data, which is just too broad for effective neighborhood planning. Tract level data for more individual languages would help cities like New York target outreach and improve equity in everything from elections to healthcare. So our ask, we urge the Census Bureau to publish more detailed language data at the census tract level where counts are meaningful. We recognize the need to protect confidentiality, but we know there are proven methods like data suppression, statistical noise, or synthetic estimates that can do so. Relying on broad national level thresholds underrepresents local realities, especially in places like New York, where individual census tracts may have dense concentrations of specific language groups. And while our focus today was on New York City, these challenges are not unique to us. Cities and localities across the country are grappling with the same issues. So finally, the ACS is an incredibly rich and powerful data source, but with more granular language data, it can be even stronger, supporting more equitable, data-driven decisions nationwide. I want to thank you all for listening at this, end of the conference today. This is my contact information if you wanted to reach out, and thank you very much.
Thank you so much, Erica. What a great presentation. And now our last presenter before our question and answer session is Chase Sawyer. Chase, it's all yours.
Awesome, thank you. Let me go ahead and I'll share my presentation. All right, perfect. And so, again, I'm Chase Sawyer. I'm a technical lead at the Census Bureau for model data product development. And so I'm going to talk a little bit about how our area in the Census Bureau utilizes the ACS data to go ahead and support disaster recovery. And before I get started, I do want to recognize some of my team members in this work. There's Bethany DeSalvo, Heather King, and Joey Marshall. But of course, there are other people here as well that are assisting with this work. Also, I just want to note that that this presentation is some of my ideas and what I'm hoping to do, but they don't necessarily represent the views of the Census Bureau. All right, and so as I get started today, I'm going to talk a little bit about why the Census Bureau is interested in measuring resilience or social vulnerability. And then I'm going to talk a bit about how we have a data product that does this and how we're hoping to kind of grow a data product suite going in the future. And so we're very interested in helping to measure social vulnerability or community resilience because we realize here at the Census Bureau, within the firewalls, we are lucky to have access to the internal Census Bureau microdata. And so in 2020, about the time that COVID was really ramping up, our team really wanted to go ahead and see what we could do to help with this. And where we landed was that we could help create modeled estimates of social vulnerability utilizing the ACS microdata and modeling techniques. And so we go ahead and we dive into the ACS data and we actually look at these components of social vulnerability. And because we're able to see that microdata, we're able to see where people have more than one of these components of social vulnerability. And so on our end, we think that's extremely helpful because it lets us see where someone might have maybe one or two vulnerabilities, or where someone is really latent and is going to have issues coming back from the effects of a disaster. And so we look at these 10 components. They include things such as poverty, single or zero caregiver, and communication barriers or age. But we go through each of these for each individual and each household in the American Community Survey. And so one example here is it looks like there may be issues with seeing my screen. Hopefully that's not, I can stop.
Nope, we can see your screen reasonably well.
Okay. All right, so it's coming through okay then? I was just seeing some stuff in this chat saying that maybe they weren't, but hopefully it's coming through okay. And if not, hopefully I'm talking through it well enough. But when we're looking at our components of social vulnerability, again, we're starting with the individual or the household level. So we go to the ACS data and we look to see if an individual has one of these components. So with the vehicles worked or vehicle access example, we go ahead and we see, did the responding household say that there were no vehicles access? All right, I'm going to try to just refresh on my end real quick. But yeah, hopefully that's coming through okay. So sorry about that. We go through then and tabulate these and apply small area modeling techniques so that we can release estimates. And the results for the community resilience estimates are that we provide an estimate of the number of individuals by the number of vulnerabilities that they have categorized into 3 groups. We have those with 0 components, those with 1 to 2 components of social vulnerability, and those with 3 or more components of social vulnerability. And that's what we really consider to be the most vulnerable group, is those with 3 or more components of social vulnerability. And so nationally, just to provide some context, we see that there are about 35% of the population that has 0 components of the social vulnerability. About just below 45% have 1 to 2 components of social vulnerability, and 20.4% of the population have 3 or more components of social vulnerability. And again, as we're doing a lot of our research trying to determine if we think a place is has a large number of the population that's socially vulnerable, that's the group that we're looking at. And so all that is to say, we go ahead and we utilize that information. That's a data product that's available, and we hope people are using it to go ahead and understand social vulnerability in their communities. And so now, as I kind of transition, I'd like to talk a little bit more about how we want to take this product and again, pair it with additional data from the American Community Survey, other Census Bureau data, as well as other federal data to go ahead and help with emergency management. And so there are 4 phases of the emergency disaster life cycle. There's mitigation, preparedness, response, and recovery. And we're on our end, we're kind of breaking those into 2 things and trying to focus on data products we can provide before a disaster event to help with mitigation, as well as after an event to go ahead and help with response and recovery. And so on the before a disaster side, our team is really trying to focus on helping state and local governments before a disaster. And so that's part of that is providing tools to our stakeholders, such as data sets. And we've also gone ahead and created visualization products as well, so individuals can access that data more simply. And so we have the Community Resilience Estimates Viewer, as well as the community resilience estimates ranking tables. And so this is an example here on the right, where we've gone ahead and provided rankings for each of the counties in the nation, as well as census tracts. And so I'm actually really proud of this example that Mecklenburg County, North Carolina, where Charlotte is actually the county seat, has gone through and utilized this to go ahead and analyze how they compare to the rest of the state of North Carolina, as well as how do the census tracts there compare when it comes to social vulnerability. And so on this other side, I also want to talk about what our team tries to do when disaster strikes using the ACS and the community resilience estimates. And so when there is a disaster, such as Hurricane Helene last hurricane season, we do reach out to our stakeholders, our federal, local, and state governments to see what we can do to help fulfill their data needs. We also try to write up quickly information about the impacted population and provide statistics about what's going on in those areas. And so on the right here, you're able to see we utilized this community resilience estimates as well as ACS data to go ahead and describe counties that had a major disaster declaration after Hurricane Helene. And we were able to see that it was, in this instance, speaking again about Mecklenburg County, it was important to break Mecklenburg County out of the other counties because Mecklenburg County was much more rural and the other counties were much more rural in the disaster zone in North Carolina. But we went through and were able to show that places with a disaster declaration were more likely to have mobile homes, have people with a disability, or be age 65 and over, and also had a higher percentage of the population with 3 or more components of social vulnerability. And so, again, we wrote this up to again, start to describe and show our capabilities utilizing ACS and Census Bureau data. The other major event that was related to Hurricane Helene was members of our team were deployed to FEMA's National Response Coordination Center. And so there we helped with providing FEMA contacts both in response and recovery with census data as quickly as possible so they could make data-driven decisions. And so something that really stood out to me as part of that exercise with assisting FEMA through Hurricane Helene was that at least my focus at the time had really been on the Census Bureau's population data that we have. Great population data here at the Census Bureau through the American Community Survey and other sources. And so I thought, okay, this is what we bring to the table. Let's show that, and then people can do what they need to with it. But what I really was able to see in that time was that there's actually an intersection that we need to address in our data products. And so, of course, Census Bureau has population data we can provide, but when we're thinking about disasters, we also have to think about the impact or the exposure that occurs after a disaster, as well as what disaster recovery is going to look like and how that is going to go forward. And so on our end, we're beginning to think about how we might create a data set that accomplishes this. And so we think we can provide census data for population information. We can begin looking at NOAA, National Weather Service, and Department of Energy for disaster impact data. And then FEMA has recovery information available through their open FEMA portal. And so my hope is that in the near term, we can begin, and we've begun development, but hopefully we'll be able to release a version of what I currently am calling a Census Bureau's Assessment, Recovery, and Evaluation or CARE data set. And my eventual hope would be that this is a data set that we can create for every declared disaster that provides timely information about communities before and after a disaster event. And just as an example of why this is important, here's an example of what I'm hoping we could do with such a data set. And so in this example here, we go ahead and compare the FEMA registrations for individual assistance to the number of households that have a declared disaster for Hurricane Helene, where people were able to go ahead and apply for assistance. And so overall, in the open FEMA data, we can see that there's almost 1.5 million registrations in counties that have this eligibility to apply. When we look at the 2023 ACS 5-year estimates, there's almost 8 million households in these declaration areas. And so when we try to look at this proportion, we see that 18.4% there's 18.4 registrations per 100 households in these counties with the declaration. When you look at this overall, though, you can definitely see that there are areas where there were more registrations and less. And so my hope is that we can continue to build this out so that we're able to go ahead and add in the information about disaster impacts and understand if the individuals that are in need of assistance are receiving it. And so some of the future work that we're planning to implement with CARES is, again, publishing this Hurricane Helene data set. We also want to look at creating a data set with 5-year ACS estimates before and after disaster events. So we're doing research on what disaster we might do this for. And our plan is to publish these data sets through the experimental data product series at the Census Bureau, so we're able to receive and incorporate comments. And again, just grateful to have this opportunity to go ahead and speak here today. If you'd like to reach out to the Census Bureau to begin to provide comments on that, we have an email, which is sehsd.cre@census.gov. And I look forward to any questions you may have. So thank you.
Great. Thank you so much, Chase. Really appreciate it. Really impactful work. And I'd like to ask all of the presenters to turn your cameras on and join us now. And we'll see if, wonderful. So we've had a few questions come through. They look like there are a number for Chase right now. I think Pei answered some of her questions already, and they've been answered and published. But I'd like to ask just one general question that anyone can respond to, which is just, we're talking about using these data for planning. So the goal is to really see improvements on the ground. So how do you hope people and audiences will be using your data? I think some of you addressed this, but I'd like to hear, from each of you about how you'd like to see your data be used. Anyone can start.
I'll go ahead and start since I was the first presenter. As I mentioned before, this data will be combined with many other different data sources to create this sort of like online simulation model where people in the community can, look at. So I talked about how just the number of women of childbearing age, so they can sort of like determine what the number is within their community, whether it's the state of Texas, which we're working on right now, but also broken down into the different region, and then be able to determine like, okay, we need resources because there's this huge group of people that are coming into this area where they could become pregnant. And there's a huge increase in, say, non-Hispanic Black women who are at greater risk in that area. So be able to use that sort of simulation model to determine what resources are needed.
I'm happy to chime in next. As I mentioned in my presentation, our story map has been used for things like figuring out where cooling centers might be, or it can also be used for to identify areas where folks might need help with evacuating during emergencies and extreme heat, and things like that. We're also planning to update the story map annually as new data comes out, and like reassess as needed, to see if like our priorities and resource allocations still continue to align, as time passes.
I'll jump in. So our LEP data for poll site assignments for language services is, of course, being used to determine which poll sites need translators and what material needs to be in different languages. And we'll continue to do that. And we assess that annually. We just delivered the 2025 file over. So it makes a real impact, annually on which poll sites get targeted for this additional service. And it really makes an impact for our communities.
Yeah, and on our end, we would just love people to utilize our data to go ahead and, again, make these decisions to better understand their communities. And again, our real hope with doing this was that we could try to distill down all of the reasons that there might be social vulnerability in a community and provide that easy to understand metric. And so, we just love people to utilize it for that.
Great. And now that more people know about it, at least in the session, I think that will start happening. So there are some questions related to your presentation, Chase. The first one is, how does this compare with CDC's SBI estimates?
Yep. No, and that's a great question. And so on the edges, there are things that line up. I do think, as I've looked at this, though, there are some major differences. And on our end, we really contribute that to the fact that we're utilizing the Census Bureau microdata to go ahead and do this analysis. And as well, again, keep that correlation between the people as opposed to just looking overall. And then, again, there's some margin of error stuff there, but I really think it's that individual look that that's where we see differences with SVI.
Yeah, and there's a related question here. Is the CRE impacted by the halt on the SBI, or is it still functional, planned to continue in the future?
Yeah, best I know, we're still moving forward. We haven't received any indication as to stop for the creation of the CRE. And actually, we published in February, there's a 2023 version of the CRE. And I should have mentioned this earlier because this is a group that would appreciate it, but we utilize 1 year of ACS data when we're doing this. So each iteration of the CRE utilizes the 1 year sample and the modeling techniques. And so, we plan to keep moving forward. We also released a version for Puerto Rico last week. So I think, again, groups see the value in these estimates.
It's great. And somebody made a comment that they'd love to see this for Florida as well. So.
Oh, okay. Yeah, definitely. Yeah.
Okay. Next question is, what is the rationale behind top censoring the number of social vulnerability indicators in the CRE at 3+? Do individuals characterized by more indicators simply occur too infrequently to report effectively at high spatial resolution?
Yep. No, and that pretty much gets at my answer there, that we top code there for an empirical reason, just to make sure. And then, once you get to 4 or even 5, there's just not many people that have that level. Of course, I've been talking about how we look at it on the internal data, but I've also looked at it on the PUMs. And if anyone wants to look at it on the public use data, you can see it fall off. So that's why we don't go any further.
Great. And then finally, are you able to provide local emergency managers with the microdata that goes, I think I know the answer to this question, but goes into the CRE to inform more strategic decision-making in response to a disaster, or provide them with the data at higher spatial resolution?
So I think, on the face of it, my expectation is that we wouldn't provide microdata. At the same time, though, Kate, if there's interest in talking more about this, I think we are looking, again, like I mentioned, for our partners in this and to understand the uses and the utility behind doing those sorts of things. So again, we're open to conversations about how we can partner on that.
Great. I don't see any other questions in the box right now. And some, again, I'll have one closing question then for all of you. And some of this was addressed in your presentation, but you can refresh us. What are the next steps? What would you like to, where would you like to go if there was unlimited time and resources to make your projects, go that next step?
Okay, I'll go first. I talked about how we're looking at the different data sources, like the different inpatient data sources. So if I had unlimited time and resources, I would find a way to link ACS data with all of the different inpatient data sets. I know there is a process. I know it's a complicated and expensive process. So if I had the money, I would find a way to be able to link all of the state level and hospital records with ACS data.
I'd say for us, it's ideal if we could add even more indicators, like we had to select some priority indicators, but with unlimited time and resources, we could potentially explore more data and add more indicators, either to the story map or a report or something like that, if there was, a better format, since we want the story map to still stay focused on a story. But of course, it'd be great to have more data and potentially explore things like the intersection of the data points. Because right now the indicators are more separated, but if we wanted to look at something like the cross-section of all the Asian race ethnicity groups, for example, I think that could be really interesting, or even potentially developing maybe an indice that's more specific to our county and our county's needs. Those would be great on our wish list.
Is there one indicator pay that you believe you're missing that you would love to have included?
Ooh, that's a great question. I think off the top of my head, it isn't an ACS one specifically, but we have an indicator around like modeling housing that may not have air conditioning, and I think being able to do further work on that somehow, to have it be even more accurate and specific, I think that's a really big need in our county, which has a lot of older housing without air conditioning.
Great.
Ours is no surprise. More detailed language data at the census tract level, not even to use at the census tract level, but to build up to our, different areas of geography that we're using for, a whole bunch of different use cases, neighborhood level, pool site area level, healthcare area level. So for me, it would be the more detailed at the language data.
Great. And Chase, you can close us out.
Yeah. No, there's a lot of things on my wish list, but maybe we could do another 15 minutes. But again, I think on my end right now, again, we'd really love feedback. Like, we have ideas and we've started to talk to stakeholders, and we are beginning to really understand where we intersect with this kind of situation with emergency management. But again, we want to create meaningful products on our team. And so, again, continuing to receive feedback on how to make these better and what data points you could use would be great for us.
Great. I suspect you'll get a lot of emails following this session.
I hope so. So that's great.
Excellent. Well, I don't see any additional questions in the Q&A. We can go ahead and wrap up. It would be wonderful if you all could join us for closing remarks. Closing remarks will happen around 5:20 or so. So please be sure to join us. We'll wrap things up. And it's been a great conference and a great session. Thank you all so much for presenting such interesting work. It's always really encouraging for me to see how the ACS is used in these really direct and life-changing and life-saving ways. So really appreciate it and the work that you're doing. Take care, everyone.
Thank you, everyone.